I would like to introduce Sonja Hintz. She is an RN, and she's also a mom, so she's got a really good perspective on a lot of this, and she knows the labs very well because I've heard this talk before, and there were lots of questions. One of the things I really like about Sonja is that she has a recovered child too, so we're very happy to hear all the advice that she has to give us and teach us about the labs. So please welcome Sonja.
I think one of the goals of this presentation is to look at how we view our children behaviorally in a medical world. Part of the problem we have currently with the model of autism that we're working with is there's different arenas, and they look at different areas of autism. Autism is really a description of behaviors versus phenotype of underlying medical condition. And today we're going to try to look at how behaviors might correlate with the physical finding. The traditional theory of autism was from Canner, and it was that we are all refrigerator moms, and it's how we treated our children that they ended up the way they did. And this wasn't really even that long ago. And so the problem becomes is as we change our autism in the presentation, we have not changed some of the models of which people operate from. One of the traditional theories is that autism is a lifelong condition, and like Dr. Jepson said, and just like I was told, your child, this is the way he is, accept it, and get his affairs in order. And that's kind of hard to do as a parent because you know there's more in your child than what the other professionals might see. And in addition to that, you've heard different areas of autism have different medical conditions. So for example, if you have an immune kid, or you have a gut kid, or you have a STEMI kid, it's really not a one-size-fits-all treatment. And so it becomes really hard as a parent to go through what your child is and what they have. So today, hopefully by going through some of the labs that you can have run on your child, it'll help you figure out what area your child needs some assistance. So actually the latest statistic now is 1 out of 100 and not 1 out of 150. And you cannot have an epidemic of autism and have it be genetic only. So these are some of the questions that we need to ask ourselves as we try to look at autism differently. We really need solutions now. We can't wait. If the numbers are increasing, as practitioners and as parents, we are not only trying to fight our daily lives at home, but we also need to help professionals see our children differently. Mainstream views on autism, there's no cure, okay? And what happens is then is those of us that really believe there's a medical condition here that can be treated fight a battle every day in our professional world. But then as parents, you see improvements when you do certain things and you go tell your practitioner and you lack the support. We need to change some of these models that we currently have. So the traditional approach says that it's a mental disorder, not a medical disorder. The ICD-9 code 299.00 in the States is not considered a treatable condition, and so oftentimes physicians won't treat your child if you have a child with autism. The biomedical approach that Dr. Jepson reviewed prior and the one I'll go through today, we try to look at the fact that there's actually an underlying physical condition that your child has, and we use that framework to develop a treatment. So autism can be treated. We actually do have children that have recovered. Not all children recover, and there's also this thought that, well, if I do this, then this will happen and my kid will recover, and that's not the goal. It is, again, the quality of life that your child has. However, if you give a treatment and there is improvement, whether it be not head banging anymore, whether it be sleeping through the night, and you know there's a physiological basis for that behavior, not to give that child medical treatment is unethical. So we need to change this paradigm that we're currently working under. If it's not treatable, then there is no unethical portion of not giving treatment. This is my son that I had to figure out what was going on with him physically. Ironically, the gentleman in the blue recliner chair is my father-in-law who passed away from Alzheimer's a year ago. My son had lost weight. He had just like, his hair was thinning. He had a sour breath every morning, poor sleep, frequent night waking, his floppy tone. As you can see, he's kind of hunched over. His fingers are straight at his side. Okay, so I had to look at some of the behaviors he had and look at it differently. Well, what is his physical presentation? I was told those symptoms he had physically were actually autism. But as a nurse, I saw him as being physically sick. I saw the behaviors, but I'm like, that doesn't make sense. Something happened. He doesn't look right. Dr. Rimlin is the founder of Autism Research Institute. And he, 10 years ago, in '99 was my first day on treatment. And it's a wonderful webpage to go to get information on studies and to look at treatment modalities that helped other children. He believed that even then that autism had a physical underlying issue. So why is this so hard as a parent to work with different practitioners or even ourselves to understand this? I like this picture because we all have to go through a paradigm shift in our mind. So how many here actually see a duck? How many see the rabbit? You guys see it now? Okay, now try look at both at the same time. It hurts. It really hurts, okay? I think that's how we feel some mornings when we wake up and we have to figure our kids out. It hurts to really change that paradigm. Medicine needs to do this as well. So if we're going to redefine autism as a physical illness, then doesn't this imply that treatment is available? I can remember being so frustrated not having I work with a wonderful practitioner right now, Dr. Usman in Naperville, but at the time I didn't have anybody 10 years ago. I had to figure it out myself. And I can remember being so upset, and my husband said finally, Sonja, you have to look at it like you're the coach. You decide the treatment team players. And if you don't like some of them, trade them, fire them, go somewhere else. And at the same time, as a coach, you're going to have to educate the professionals you're with. And sometimes that gets real frustrating, but it's very important. You need to do that. So as you try to figure out how to educate the people you want to help you, you're going to need to help figure out how to explain your child to them in a systematic way. So write down some of those conditions like I did with my son. Examine your child. So if he has a certain behavior, try to figure out when does this behavior occur. Did they happen before or after something my child ate? Are there signs of pain? Counter pressure, biting on the wrist, leaning over objects. Those are all things that show that something has occurred. And when does this happen? Like the ball that Dr. Jepson saw with that boy sleeping on the ball. He obviously had pain at night. Okay, so what's happening at night? At our practice right now, we have over 1,500 kids worldwide. We have a variety of kids that are mild to severe, and we have to look at how their physical presentation of their symptoms affects their well-being. So why do we have this situation? There's many causation of theories. We have autism, we have genetics, environment, biological, immunological triggers, and the timing of things. So some kids have issues from birth. Some have autism start at age 2. You have to go back in your child's history and figure out, okay, when did the symptoms appear? So for my son's sake, he was very stiff as an infant, had colic, so you have to look at the whole picture. And then as we look at the timing, we have to figure out what part of the system is being affected in our children. So whether it's heavy metal overload, oxidative stress, mitochondrial dysfunction, gut abnormalities, chronic inflammation. So again, let's think of this different now. If we have autism and it is medical, what do we need to do? We need to take a really good history and physical exam, lab testing, look at the environment, give those foundational nutrients, support some of the underlying immune issues, and then look at methylation, heavy detox, and some kids do benefit from hyperbarics. In our practice, we look at intensity of symptoms, and the more problematic a symptom is or behavior is, the more intense we need to get with our treatment modalities. So what are some basic labs? If a typical child goes into the doctor's office and he's chewing on inanimate objects, putting things in his mouth he shouldn't, they consider that pica. But in an autistic child, it's often considered a behavior. Okay, so if you take away the autism and just look at the fact he's eating at something, it's called pica. Well, we would typically do an iron level. But in our practice, our iron levels tend to be okay, so we do a ferritin level on top of that. And ferritin is what's stored in our body. And that's what carries the iron around. It's the iron stores where our iron comes from. We look at thyroid, we do a blood lead level. Blood lead level, however, you have to keep in mind the body doesn't like lead, so it stores it right away. So when you do a blood level, if it's high, or even some in the blood, you're going to need to think current exposure. I'll go over lead a little more specifically later. We do a plasma zinc, a vitamin D hydroxy level, especially those of us, I'm from Wisconsin, so there's not a lot of sun there either. And then we put sunblock on our kids so they don't get sunburn. This is all contributing to a vitamin D deficiency. Blood ammonia. If a child after eating food becomes kind of hyperstimmy or have issues, a blood ammonia is really good to check post-perennial after eating their food instead of like fasting. Because overnight fast, there's not going to be any protein in the body and the ammonia might be fine. And ammonia can cause kids to have difficulty actually in learning, paying attention. And then the serum copper, because a lot of the kids have high copper and low zinc. So the reason to run some of these labs in a clinical setting would be weight loss, frequent infections, poor tension, picky eating, maldigestion. These are actually codes that you could use, poor growth. And to add to those, this list is a very long list. I'll try to break some of these down as I go forward. But these are some of the testing that we do in our practice currently. Okay, so immune dysregulation, how do we work that up? One of the things you can do as a parent and as a practitioner is there's a great resource called PubMed. If you type in PubMed in the Google engine, you can actually type in Th1 and Th2 and actually come up with some research articles and start educating yourself on what that is. And in our kids, these are some articles that had came up. Pro-inflammatory cytokines in the brain cause the microglial activation. They can cause the abnormal EEG, seizure activity, and then the autoantibody piece. You can do ANA titers on kids for autoimmunity. We haven't really seen that to be affected. But when you're looking at specific process of anti-myelin basic protein, that has come back in some of our kids. So let's break down the behavior of excessive chewing. It could be anemia and it could be lead poisoning. And so to rule some of these things out, we would do a CBC, a porphyrin, an iron, ferritin. The TIBC is total iron binding capacity, and a blood lead level. Because right now, children are in a rapid rate of growth, so they absorb more lead from their environment. In the city of Milwaukee, when I was a public health nurse for the city of Milwaukee, we had noticed an increase in lead toxicity when we added fluoride to the city water. And I think if you look at the research, you know, as public health nurses, we noticed there was some more lead in the kids, but we didn't know where it was coming from. A lot of them were in older homes. The assumption was it was from older homes. But as I moved forward into biomed for autism, I came across research, too, that also showed that fluoride does increase lead absorption. The lead burden, we know, and it's well documented, can cause a learning disability, hyperactivity, delinquency. And when it's with mercury, they have a synergistic effect. So how do you evaluate lead? Remember I said if you do a blood lead level, it's a current exposure. So you get a kid, you do a blood lead test, and it's not that high. So it's very hard to do because the body doesn't like it, it stores. In our practice, we often do provocative testing, but it's not necessarily convincing because if you give an agent, like calcium disodium EDTA, try to get the lead out of a child, you're assuming all the detox pathways are open, and so when you collect that urine, you're actually going to see something, and you may not. We can sometimes look at hair analysis. It's a 3-month window backwards. If there's been some studies done on hair analysis in the children, and there's low levels in the hair. Well, if it's not in the hair, where is it? It's in the body. Lead seeks bone, so you can only really find it 12 hours after exposure. So one other test we do is a urine porphyrin test. This particular one's an older test. Now they have both parameters on there for the creatinine on the bottom. I don't know if you can see that, 725. So the handwritten part is correcting it based on the creatinine. But this is a test that was ran out of France. And what it does is it looks at different steps of your red blood cell going through the process of becoming a mature red blood cell. And so each step of the way, the red blood cell is a porphyrin. And the porphyrin is blocked by an agent with a charge. So as it goes through, these will be increased if there's a block. The one thing you have to remember about interpreting this test is if you get to the bottom where it says coporphyrin and you have a normal range, that's the last step. So if the step before is high and the step before that is high, it could be normal because the other levels are high. So there's also a science and an art to reading lab tests. The next thing we look at in our population are STIMI behaviors. Most of you probably know what a STIMI behavior is, but it's where they can have verbal tics, they can be perseverative on an object, fast forwarding a video or rewinding the video, scripting, saying the same word over and over again, obsessed about placement of objects. And in the general pediatric population, there's a condition called PANDAS that is well documented to cause these same behaviors. So in a child with autism, you have to look again at the literature for PANDAS, not as it necessarily relates to autism, to find information. The blood work we do is an ASO titer. Now an ASO titer is like a current infection in the blood, and my next slide will show you some levels and examples of that. There's an anti-DNase B for strep, and if you're writing that on a script, you gotta sometimes write for strep because they'll think you're looking for antibodies to DNA. And then there's quantitative titers. So the reason we do this is the OCD behavior necessarily PANDAS or is it viral related? When we have that many patients that we see and we treat over years, we start to know phenotypes of kids and behaviors. So STIMI kids can be strep, and we also notice STIMI kids can have viruses. So here's an example of a lab test. It happens to have a ferritin on there. But, and as you can see, even in this child, the ferritin is somewhat on the low side. So what we would use in that case is lactoferrin. The problem with lactoferrin is it has milk with it, so you kind of have to watch it. But actually, some kids who really need the ferritin part do well. Once the ferritin levels come up, all of a sudden the sensitivity to the dairy is more obvious, and then we can back down. The strep there, the anti-streptolysin is high. That's 490. And that's a current strep infection. Now the next one, the anti-DNase B strep antibody, is high. And what happens is this is long-term autoantibodies. The body starts to make autoantibodies, in this case sometimes to myelin in the brain. So what do we do? Well, first off, if you have a child who has a food refusal, it could possibly be that he has current strep. I have one child's presentation of strep is simply to become more abusive to the sibling. I have another patient who becomes more OCD, and another one that actually talks crazy talk, mom says. And every time we've taken him, this crazy talk child actually turns positive in his throat culture. But he never has any fever. He never shows any outward sign of actually being sick. So when you think of strep, we have to, again, think a little different, switch that paradigm from a rabbit to a duck, and try to figure out, do our kids have these presentations? As far as treatment strategies go, we have used Ithromax in the past, or Z-Pak, and different antibiotics, but we really like to try to use natural agents like berberine, golden seal, Oregon grapefruit, and then we also had developed the biofilm protocol at our practice. When we've implemented our biofilm protocol with strep, we've actually had titers come down. Okay, next area, mitochondria. These are the energy powerhouse of our body. They help make energy for every cell in our body. And oftentimes, again, what is our signs and symptoms of mitochondria? In a typical child, you might see them have low energy and low tone, low muscle development. And we see that also in autism. GERD, too, is dysmotility or reflux. It's another sign of mitochondrial issues. Here's some literature to support that, yes, indeed, mitochondrial disorders are found in autism. Carnitine deficiency, Dr. McFabe's also looking at carnitine and propionic acid, and that if there's an issue with Clostridia, you're going to be depleting carnitine. If you do a blood test for carnitine and it's normal range, it does not rule out that that child still would not benefit from carnitine. Because remember, Dr. Jepson said it's an absorption issue and utilization issue. So sometimes we have to drive that system and give extra. So what are some of the testing? Ammonia plasma I spoke about, lactic acid. Lactic acid is a byproduct of metabolism if the body's breaking down muscle tissue fast. So one thing you have to keep in mind is test is as good as it is collected. I had a parent, how many of you have to hold your kids to get a blood test? Okay, if you get a lactic acid on that child and the parent has to restrain them, they're fighting you. Okay, so that if a lactic acid comes back high, the assumption cannot necessarily be that they have high lactic acid. You're going to need to report to your provider, was the tourniquet on or off at the blood draw, and was my child needing to be restrained? So that test is can be tricky. Carnitine level, pyruvic acid, urinary methylmalonic acid, that's also in a MAP and an OAT test that I'll go through later. The urine, but you can order it by itself through Quest in our country. So here's a map. Again, this test is a byproduct of things that are in our body. Okay, this is a urine test. So if it's high or low, things are either blocking it or you have too much of it. Okay, so each result here will depend on that. Number 1 through 12 looks at the GI tract, and in this particular case, number 11, the arabinose is high, and that is a yeast metabolite. So the yeast are happily growing in your child's intestines, and it's off-gassing in a way is the best way to describe it into the bloodstream, causing certain behaviors, and then when your child, you collect that urine test, you've actually captured that byproduct. What that says is if it's in the gut, because we all really have all different bacteria and yeast in our gut, and it can be caught in the urine, your child has leaky gut. So you could treat the yeast, and you can keep treating the yeast, but if you don't help repair the gut, then it's a vicious cycle. The other thing on this test in this particular child was find number 8, the DHPPA is the Clostridium marker that we see high in a lot of our children. And then the neurotransmitter metabolites is on here, and the energy cycle. I like to take this page, 20 through 30, and use this one. I can remember taking biochem at Marquette thinking, oh God, just get through this, I'll never need it again. And this is all I do practically now is look at these test results. I had to relearn it. And as a parent, you can too. You can learn this. This test, how to interpret this would be to look at each step of the Krebs cycle. It's a citric acid, and it's kind of a clock that goes around. And the things in the inside of that circle on that test, green, are the things that are go. They make it work better. And the red are areas that block. So if you have a particular elevated area, you need to look at what's in the red. And in this particular, alpha-ketogluteric acid is high. What's interesting is this has been shown to be excitotoxic. Kids are stimmier and hyper. So we give GABA, which actually have to be careful because GABA can affect the alpha-ketogluteric acid level. Now, we have, in our practice, we use succinic acid. Whoops. How do I go back? On my screen, you guys still have it. We use malic acid sometimes. No, get rid of the screen here. Oh, thank you. We have malic acid that we use. We use the different steps. We use glutathione. You can see that on the inside of the circle as well, in IV, oral, and transdermal. When you have a child that has a carnitine deficiency, if you look at the top, there's fats, carbohydrates, and proteins, and all these things need to be broken down and fed into the bottom circle. If the adipic or subaric acid are high, oftentimes they have a carnitine need. If you do then say, well, if it's blocked there, maybe I should do a carnitine level, and that comes back normal, then it's a utilization issue. So then again, the child would still benefit from receiving some carnitine. And these are some of the various vitamins that support that enzyme pathway that you saw before. CoQ10 is interesting. Complex 1 in the mitochondria can be affected in the kids, and CoQ10 affects it. And I've had a lot of parents add CoQ10 and report not much change, and I think maybe we're looking at using too small of doses. Because if you actually look at the mitochondrial research, they go real high on CoQ10, 500 a day almost on an adult. Acetyl L-carnitine, that acetyl group on the L-carnitine is important, carries, and the other thing, carnitine too, there's different forms, fumarate, tartaric, there's level carnitine, so you have to pay attention to the form that you use as well. Okay, immunizations. As a public health nurse, I gave in one day 300 vaccines, but I never asked if a child was sick, do you have an egg allergy? You know, what else is going on in that kid's life? I just gave it at a clinic. I think we have to keep in mind, again, one size does not fit all. We don't need polio here. We don't need to have outbreaks of measles. But we also can't assume in this population of children then that the one-size-fits-all model works. So how can we look at immunization practices differently? We can do actually levels to see an immune response to a vaccine. For example, my daughter Hannah, who came after my son, I didn't know what to do, but I didn't want her to get polio. So I gave her one polio vaccine and checked her titer 3 months later and again a year later. And that one titer had to be 10 or high, and hers was 110, so she's protected. So when you're checking immune response, you have to check for quantitative titer and actually write that out, because a qualitative just tells you yes, they have immunity, or no, they do not. Here's an example. This child had a bunch of titers run. CMV titer was low. Epstein-Barr was low. Now measles, mumps, rubella. So rubeola is measles. When you ordered a quantitative titer in this child, to be immune needs to be 20, and this child's greater than 100, so this lab didn't even have the ceiling number on this particular test. So maybe only one vaccine was needed. So the next area we look at is GI tract. Now, if you have a picky eater, why are they picky, and what behaviors are they showing? Some of these things we've gone over. And so, again, remember our team approach here. Your GI doctor has to be a team player as well. You need to actually present your child to that doctor so that you can have effective treatment. So, for example, when your child is having difficulty bowel training, I was told, well, that's autistic. He doesn't, you know, that's typical. Actually, what it was is he was severely constipated. He had a mitochondrial issue, low carnitine, poor motility. So once I gave carnitine, his motility improved. Guess what happened? So did his bowels improve. But the behavior piece was still there, so we did have to put into it a behavior program. Once we helped him fix his biology, the behavior program was even more successful. So in that case, you want to have daily bowel movements are really your goal. Having them every other day or twice a week, that's not enough. You need to add digestive enzymes with meals. If they have reflux, I actually give you caution on adding enzymes first, because if you're constipated, you need to fix that first, then get them going. Because if they have GERD, those enzymes are sitting in the stomach and they're going back up into the esophagus. So actually, I think it's a better place to start with some probiotics, working on the diet, make sure they're going, and then adding the enzymes. And diet maze, many different diets to do. So again, you're going to have to think about your child, their behaviors, how they present, and look at these various diets and see if it fits your child. Some testing. When you go to a GI doctor and your child's constipated or having a difficulty going, they see the autism. So you might want to give examples of some behaviors your child has so that the GI doctor understands what your child has going underneath on the underlying process. Picking or scratching at the rectum, frequent night waking, smelly stools, refusal to be toilet trained, are some of the GI issues that our kids present with. And then on the other side, there's some testing that some general testing is done. Take a picture if you have to, like Dr. Jefferson showed earlier, and bring it in. Videotape a behavior. You know, bringing in a stool sample itself can be helpful in a jar. You can threaten to open it up if you don't get help. Microflora. Okay, we have bacteria in our guts, right? So what's it doing there? We have to figure out how can we help this process. Probiotics are important because what they're going to do is they're going to crowd out those bad guys in our gut. So if you give beneficial flora, it tells the other guys to leave. And we need those because the good bacteria help break down our food. So what are some of the abnormalities in the clinical research that we see? We have maldigestion, malabsorption, dysbiosis, and gut inflammation. And again, those are some of the articles. So in our practice, we look at some stool testing. And again, that MAP or OAT test also had those markers of metabolites of bacteria. So here's a stool test. And the beneficial is in the green. There's bifido, E. coli, and lacto. Now in this child, the bifido is kind of on the low end and the lacto is on the low end. It needs to be all fours. Some kids, when you give them a real heavy-duty probiotic, they regress or become constipated. And again, you have to think back in your mind about the immune factor. Maybe they're making antibodies to bacteria in the gut, even their good bacteria. So maybe starting with a single strain, like a bifido by itself. Bifido is actually a first line of defense as an infant. You get that from your mom from breastfeeding. So bifido, a single strain, then you add the next one. For good E. coli, Mutaflor is a product that you can get from Germany that raises E. coli level, and it helps with good. It's usually used too to treat irritable bowel disease. Now, as you see in here, there's an imbalance called gamma strep. They do not culture this out, but go back to our PANDAS profile, STIMI behavior, leaky gut theory, and if there's no strep in the blood, the kid's acting obsessive, and you find strep in the gut, I think that's the place to start then, if looking at treating that. Klebsiella is also listed here, and rare yeast. This particular panel has other markers on it. Some kids, you know, you've heard about responding to secretin, and when you look at the inflammatory markers on that particular test in that area there, the lysozyme, lactoferrin, WBC mucus, if those are elevated, some kids have a favorable response to secretin, as well as if their clinical picture shows they had regression around age 2, have diarrhea issues. Secretory IgA is an immune marker in the gut, and that is actually responsible for being kind of our gatekeeper and dealing with the things that are in our GI tract. In this child, it's low. If secretory IgA in the gut is low, you can check it in the blood, and the blood may be normal. So we would look at things to help this level go up, which would be probiotics, colostrum, transfer factor. Some of those things help with that. And then there's further testing. The short-chain fatty acids, if they're out of whack, are obviously, again, a sign that there's some dysbiosis going on. And the pH. You know, apple cider vinegar between meals can affect your stool pH. Using baking soda, putting in a little capsule can help actually acidic kids. In this test, it looks at saying, okay, we find yeast, what can we use against it? Natural agents are usually what we go with first before we use medications. As you can see, if you were to say my kid has yeast symptoms and you say, well, then let's just do a medication, the medication actually might make that yeast more resistant, and that's what the R part is so you would use the things it's sensitive to. Uva ursi is a short-term use herb. It's not something I would recommend long-term. And a lot of these things you start low and work with a practitioner who knows how to dose them for your particular child. Here's an oat test. The MAP test is similar. This is also a urine test. In this child, the arabinose is high. So if we treated the gut, looked at the stool test, no improvement, sometimes we really do need to look at doing an oat test. And if some of these markers are high, we use medication in those situations. So what are some symptoms your child might present with when they have yeast? The stools actually are kind of like floaty and frothy. They can have rashes. Now remember, if you had it in the stool or the urine and you start treating, oftentimes how are you going to get rid of that yeast? Okay, it's going to either die and off gas, create more of the negative symptoms as you're treating it. You're going to have a rash because the yeast comes out in the either like when you have to pee or poo it out. So kid's going to end up with a rash. So that's not necessarily all bad things. It's just you're going to need to be following that closely. Sometimes lack of potty training, in addition, can be a sign of yeast. So here's some other treatment options. Grapefruit seed extract and a phenol kit. We kind of watch that. The other thing is caprylic acid. If you have a child that has high oxalates in that oat test that I showed earlier, caprylic acid actually can increase oxalates. So you have to be careful using that one. Okay, parasites. Well, this is everybody's favorite subject. But we have to look at this as an issue for our children. And in this particular study, there's Blastus hominis in this child. I had one girl who just this kept showing up, and Dr. Usman actually, we used Flagyl in her case. She improved tremendously in her presentation. So what are some signs of parasites? Bloating, itchy butt, night waking, some of the similar things you see, but I think teeth grinding is a big one. And so even back to that pica issue, you can actually have like chronic chewing on objects if you have parasites. Parents have reported to us that there is increased behaviors around the full moon. When you have 1,000 patients plus, you start to see patterns in the kids. Allergies, again, leaky gut. So how do we treat them? We are so far from how we used to eat, be grazers, and you have pumpkin seeds and different things that would clean us out from parasites. So these are some of the herbs that we use, and antiparasitic medication if it's warranted. Remember I was saying they have off gas, so as you kill them, your symptoms will maybe get worse. So what are some of the reactions as you eliminate these things? You're going to get the irritability, the aggression. the stimminess, the skin rashes, the side effects. You have to also remember you're using agents to kill something, and the reaction may not just be simply a die-off. It could actually be a sensitivity to that particular item you're giving them. So maybe hold it for a few days and see how they behave. Oftentimes, we stop a supplement if the kid's actually reacting to it and just see. Giving activated charcoal, bentonite clay, we really can help the kids because the charcoal binds up some of the toxins. Check an ammonia level. As you kill off bacteria and different byproducts of yeast, you're going to be increasing ammonia level in the blood. And in that case, we look at using milk thistle, artichoke, dandelion root, and your liver regenerates at night, so we give these things at night. So I know there's a lot of labs in here. We use them to kind of give us a direction. So what you need to do is figure out again, go back to your child, identify your child and what symptoms they have. Here's some resources available to you. I like the Prescription for Nutritional Health and Healing. It's a general book. Keep your, I used to carry a binder around with all my kids' labs in them and make notes on them. And support group, other parents can be very helpful. Attend a lot of conferences, get information. The Dorland's Illustrated Medical Dictionary is actually a book that's like so thick, and it has in it like what is cysteine or what is glutathione. It's very helpful. Some other books that are really good that I found helpful. Special Diets for Special Kids. There's all kinds of different diet books. So once you figure out like where your kid lies on that whole diet spectrum, you can easily find books now to cook towards that. As you go forward, keep in mind that you're also not only learning about your child, but sorry to say you're educating professionals as well. And so share the success too. We often get calls when kids aren't doing well, but if something works, that's just as important. So let your doctors know that, hey, I did this and this is what happened, because it's a clue. So these are some of our kids that improved over time, and that's my son. Thank you. Yeah.
How do you know between, say, for instance, the die-off, if it's working, or if it's a bad reaction to it? Because my son has very little yeast from one of the tests that we've done, but the doctor put him on Omeprazole, that his bowels seem to be, he's always had normal bowels from birth.
Mm-hmm.
Put him on this Omeprazole, and he started getting diarrhea probably 8, 9, 10 times a day. And then it was so acidity, it would give him a rash. If I would catch it right into it, all of a sudden the welts would start coming out. So I called the doctor.
Okay. Yeah, okay. Next one, go to the microphone. She just had suggested. Okay, so go ahead.
So the doctor recommended, well, if you want to test to see if it could be a die-off effect, or, and I said, how do I know this?
What was the supplement, or is it homeo? Okay. If you give charcoal and the symptoms improve, typically it's the die-off reaction.
That's what was recommended, was the activated charcoal. I didn't start it yet, but I will. How do you know other? I guess that's one way.
Right. Then you know that it's. The other thing is we assume the dosing is going to be the same for every person, every other day or once a week. If you have irritability, you're trying to improve the child, not make them worse. So it's a balance act. So again, you might want to think about slowing the process down, cutting your dose in half, starting lower.
See, I guess what I was told was, since it's a homeopathic type of medicine, that usually dosage doesn't affect.
Right.
We get different.
Right. You just have to experiment with that.
So before actually giving him the activated charcoal, what I wanted to do was actually lower the dose myself and see if that would.
Yeah,
Anyway,
mother's intuition.
right?
Yeah,
Otherwise,
right,
before starting out, I just wanted to lower the dose.
right. That sounds good. Yes? Is it on?
Yeah, it's on. I'm just wondering if there are any side effects to using the high doses of the nutrients or the herbal medications.
Well, we don't use high doses of herbs ever. But the nutrients, yes, fat-soluble nutrients, you need to check blood levels, like the vitamin D level that I showed. You can actually do a vitamin A level. And so if they're not utilizing them properly, you're going to need to cut the doses down. Mm-hmm.
I'm curious to know what lab in the States do you use for the ISO titers?
Oh, Quest or LabCorp.
Okay. And would you use those for the anti-dephase?
Anti-D, yes.
Yeah, as well. And that was, what was that called again? Just
The strep panel.
No, sorry, the labs again.
Quest.
Quest, and what was the other?
LabCorp.
LabCorp, thank you.
And some of the hospitals in our area have their own labs that run them as well. But if you go to like even a Quest webpage or LabCorp webpage, that might give you some information. What's that? Well, the other option is find a lab here to contact them. Say what kind of tube do you use, what color it is, does it need to be spun, you know, what's your policy? And that's the hard part about my talk here today, so if anybody has any answers for families, you know, please. Go ahead.
I was wondering about the biofilm, and in a lot of your samples, the kids were high in arabinose, and we've been dealing with 8 years of high arabinose and unable to get it, and we're going to start the biofilm protocol. So I was wondering, one, if you've had specific response to the arabinose, which seems to be problematic for some of these kids, on the biofilm, and also what symptoms, because I'm very nervous about the casein component in the biofilm, in the lactoferrin, and I'm wondering what specific symptoms I should be looking for.
Okay, and some of our kids, we do not use lactoferrin. If they're have an IgE allergy to dairy, we will not use lactoferrin. As far as high arabinose over time, you also have to remember when you're collecting that urine. So if you're actively treating yeast, you're going to higher your arabinose collection in the urine because it's dying off. So that has to be taken into account as well. And then the stool testing. At some point, you may have had a yeast show up with a sensitivity. I'd go back to the old testing, pick out which one it was sensitive to, and use that as your step 2. And then we use an enzyme to break up the polymatrix, and biofilm defense is one that you can use from Kirkman. There's other ones you can use as well from Enzymatica and so forth.
Yeah, I've been sent the whole, I guess, from my Dan, your whole protocol for the biofilm, including the lactoferrin, and I'm just wondering, you know, if there's anything.
Well, does your child have an IgE sensitivity to dairy?
No.
Okay.
But
And
it's been casein-free for 8 years.
in casein, there's 3 components of dairy. So there's the whey, the lactose, and the casein. So lactoferrin does not contain casein. So I think it's the whey portion. Yeah. So it's different. So, what's that? Yeah, it's a huge talk. If you go to the Defeat Autism Now in October, Dr. Usman has it online. Autism 1, her presentation is online. And I hesitate to go into detail here because you really need to be under the care of a physician. What is it? Staph aureus is a bacteria that can make it. Okay, the best way to describe biofilm is, you know, when you wake up in the morning and your teeth feel slimy? That's biofilm. Okay, and dentists have known about it for years. They use a mouthwash now called biotine to break that biofilm up. They think it causes gingivitis. If you look at the lit review for biofilm as far as stagnant water in the bottom of ponds, engineers have had to deal with that slime. And what it is these bacteria want to stay hidden. They hide underneath that. And so if you break up that film, you find what's under. That's the catch, though, is because if you start breaking that up and you unleash what's underneath, you could have a mess on your hands if you're not doing it properly. Okay.
I have a question about coenzyme Q10 and dosages you mentioned. I find it useful, my son, 100 milligrams a day. Should I still consider increasing that?
If he's doing good at 100, then keep him there. I mean, if you notice it, if it wears off, you might just want to dose it twice.
Okay. Thank you.
VSL as a probiotic, I have some concerns about it because of the casein component in it. Because I've noticed when I've given it to some of the children, they've had some really bad effects with it. And my concern is with the casein. And, and I'd like to know what lab testing you might have used to actually see if that's a concern.
Well, it was interesting. We had this child who was really on the road to doing well and went on VSL number 3. And he had gone casein-free, gluten-free. Went through some testing, and Tracy Zeman in our office, or Tracy Bongiorno, she's married now, she did a porphyrin test, peptide test, peptide test, and the casomorphine was sky high in this kid. And we knew this family was really good at doing the GFCF diet, but the kid was decompensating. So where did this come from? It turned out it did come from the VSL number 3. And so when we checked that's through Great Plains, and that was actually high.
Is there a lot?
Not any just one. Rotation is actually the best success that we've had, is just rotating them through. The issue of that one slide that I showed you with the E. coli not like being at level 4, a lot of the kids that's low in because of antibiotic use, and so we've had better luck sometimes giving Mutaflor. It's Mutaflor. It's from Germany. To raise that level helps colonize and hang on to that the other bifido and lacto as well. Then.
Can you spell that again?
Mutaflor is Mutaflor. Oh, Mutaflor. Sorry, I'm on the spectrum too. I have dyslexia. So it's, Mutaflor. And it's from Germany. In the States, it is a prescription. Pardon? Uriel in East Troy. That's actually where I'm from, is East Troy. Pardon? We have one case that's using that currently. Mixed.
Are there any tests to examine the level of phenyl sulfate transferase, how that's working in the liver, and also to look at its substrates to see where maybe you need to supplement to reinforce that enzyme?
What test to use?
Are there any tests available?
Well, there's a test through Genova that sometimes will look at glutathione. It's called the ONE test right now even. It's pretty a good test that has a lot of different nutrient markers as well. Again, I say throw the kid in the bath. Give him a cup of Epsom salt baths. If he comes out hyperstimmy and red ears, he's got sulfur problems. I mean, it's pretty basic. Go from there and maybe do further testing.
So does that mean that he's getting something out of that bath, or that you shouldn't put him back in?
He's having a hard time with it.
Yeah.
Yeah, and so then that sulfur system isn't working. I have some kids then who we actually have to put on a low sulfur diet, like no garlic and no tomato, and look at treating them slowly to support that pathway through magnesium. And
the test that we did with Amy Asco that showed the genetic aspects of the methylation system showed that Stephen shouldn't be having anything like taurine, sulfur, B6, all the things that are being prescribed for these children, and yet, you know, he's autistic and he's possibly an overmethylator. And so what implications does that have for phenyl sulfate transferase? Because he can almost eat no vegetables or fruits or anything with phenols or salicylates in them.
yeah.
So what do you do with that?
Sometimes hydroxy B12 works in that case. Intrinsic factor, looking at the ammonia pathway as well, working on the ammonia.
Okay, thanks.
There's people on the message boards writing that if your kids are panda kids, you should be avoiding probiotics with the streptococci strain in it.
Yeah.
What is that, true or false?
In our case, we do use that practice.
You avoid it. You avoid
Streptococcus thermis, yeah.
Because I know Dr.
Thermophilus.
McCandless really likes the Clear Lab probiotic. I can't think of the Clear Labs Probiotic Complete, but that then you.
But
that
the
might
detox, Clear Detox doesn't
So
have it
just
in.
go with the detox. I know the detox one doesn't have it.
Right.
So I just thank you.
I have one more question about the colostrum. You mentioned in Canada, I looked into it, there wasn't any one without casein. So is it safe to use with our kids, or should we just
That's a
avoid
good question. You have to find one that doesn't have casein. Kirkman's here. You could talk to them about their product. They're downstairs.
Okay. One more question about the bacteria E. coli you mentioned. We went down the, I believe, comprehensive digestive stool analysis, and in one test he showed he didn't have enough E. coli, and the next one we did after he showed enough, but I still have Mutaflora. Should I use it or should I avoid it now?
In Germany, they use it for irritable bowel. So if you have symptoms of irritable bowel, keeping your child on it has been shown in their research to be effective. But if not, we usually do a 3-month course and stop.
3 months on it.
And then if they get an antibiotic, you might need to retest and check again, though.
Okay. Thank you.
All right, thank you.